but because they rid the carriage of pneumo in the oropharynx of older children, we've seen a dramatic decline in pneumococcal infection, even in the youngest infants. And in this graph here, you see in the advent of PCV7, the first pneumococcal vaccine, that there was a 40% decline in invasive pneumococcal infections, even in those infants that were 0 to 60 days of age. So what are the most common pathogens in today's era? Most of the serious bacterial infections in young infants are caused by E. coli. That's the most common, followed by GBS. The other pathogens are more minor. So there's been a dramatic evolution in those pathogen counts. All right, we're going to spend the rest of our time going over 4 cases that sort of highlight some relevant principles of the management of the febrile infant. The challenge is often in the second month of life, where you're trying to decide how much testing to do and how much empiric treatment. So we're going to start with a 5-week-old infant with a rectal temperature of 38, who's otherwise well-appearing. So this is the well-appearing infant. The rest of the birth and a history of present illness is normal. So you start with some laboratory studies. So you get a white count, which is normal, with an ANC of 3,000. The urine analysis is negative. You get a procalcitonin, which is a biomarker, and we can talk more about that. And a C-reactive protein, which is also normal. So now we need to think a little bit about whether we want to do a lumbar puncture. Is this infant at enough risk for bacterial meningitis? We need to further evaluate them. So how good is our clinical judgment? That is, as an experienced clinician, can we look at an infant and tell whether they're likely to have an invasive bacterial infection? Unfortunately not. And this is a study that I was involved with where we looked at evaluation of infants by experienced clinicians, either a Yale observation score, which is a structured clinical suspicion score, or just asking their gestalt, like how likely do you think that this infant has a bacterial infection? And this is an ROC curve where you look at 1 minus specificity versus sensitivity to look at the accuracy of a diagnostic test. And what you can see here is that neither clinical judgment or the Yale observation score were at all accurate. They were almost like flipping a coin. So you can't tell by looking at an infant which one of those have invasive bacterial infections. So we have to rely on our laboratory testing. So PCARN is a federally funded emergency medicine research network in the United States. And one of the studies that the network has conducted has been looking at febrile infants. And they initially enrolled children between 2014 and 2016 for the derivation and concurrent validation of a rule that I'm going to present. And then subsequently have enrolled another 1,300 infants in a prospective validation, which I will also talk about. Who did they enroll in this study? Infants less than 60 days of age with a fever who were having blood culture testing. So here's the rule. This is using recursive partitioning, which is a hierarchical multivariate modeling. And what they looked at is all infants. The best predictor was the urine analysis. So if you had a
recording in progress,
positive urine analysis, you were not in the low risk group. If you had an ANC that was greater than 4,090, you're not in a low risk group. And if you had a PCT of greater than 1.71, you were not in a low risk group. If you had none of those factors, you were in a low risk group. All right, how did that rule do? So in the concurrent validation, I've highlighted the performance of the rule with the red box. So the rule had a high sensitivity of 97.7%, a modest specificity of 60%, but a high negative predictive value. SBIs were uncommon, and so the rule performed well in excluding those infants with serious bacterial infections. Subsequent to the derivation and validation of the rule, it's been modified slightly for clinical applicability. So urine analysis is still the best predictor. The ANC has been rounded to 4,000, and the PCT limit has been brought down a little bit to increase the sensitivity without much of a loss of specificity. So the 3 rules in the modified PCARN rule are listed here. This has been externally validated in those 1,300 subsequent infants that we talked about. And here's the performance for both SBI, so urinary tract infection, bacteremia, or bacterial meningitis. And again, the negative predictive value is very high. And then if you're really focused on IBI, invasive bacterial infection, again, the negative predictive value is 99.7%. That is to say, if you're in the low risk group, the chance that you actually have an invasive bacterial infection is about 3 in 1,000. So back to our case, we can't use our clinical judgment, but we can apply these clinical prediction rules. And currently, particularly if you have procalcitonin testing available in a rapid timeframe, the PCARN rule is the best available rule to risk stratify these infants. So this infant is low risk by the PCARN rule that I just presented, so probably doesn't need a lumbar puncture and can be safely sent home without empiric antibiotics. So this infant went home, the cultures remained negative, they were rechecked by their primary pediatrician, and they did well. All right, we're going to move on to the second case. This is again an infant 5 weeks of age with a febrile temperature measured at 38.3, otherwise well appearing with no source on examination. This time the laboratory cites a white count slightly elevated at 12,000 with an ANC right on the cut point. The urine analysis is positive, but the procalcitonin is 0.3. So the issue again is lumbar puncture, and what's complicating the issue is the presence of the CSF pleocytosis. In a very nice study done by our colleague David Stadauer, who's now at Cincinnati Children's, he looked at a 20-center study of infants that were in the second month of life who had a urinary tract infection. And the main goal of the study was to look at how many of them had CSF pleocytosis or meningitis. So he identified 1,190 infants in that age group, and 18%, or 907, so 18% had CSF pleocytosis, although very few of them had bacterial meningitis. So the challenge is, if you know that infants with meningitis, young infants, are going to have meningitis, should you do a lumbar puncture or not? Well, although they have CSF pleocytosis or meningitis, they don't have bacterial infections very common. This is a recent meta-analysis of these infants where they looked at the prevalence of bacterial meningitis. Each line represents a study. The point estimate is the prevalence of bacterial meningitis in the included population. And overall, the prevalence is 0.25%. So of all those infants with UTIs and CSF pleocytosis, only 0.25% had bacterial meningitis. So although we know there's a fairly high percent of having CSF pleocytosis, it's a sterile pleocytosis. And the dreaded disease that we're looking for, bacterial meningitis, is very uncommon. So what should we do? Back to our infant. It's probably very safe to not do a lumbar puncture, despite the fact that the infant has a positive urine analysis. You want to treat the urinary tract infection, and that can be done safely outpatient with an oral first-generation cephalosporin, and they can be sent home. In this case, the infant did grow E. coli, and as part of the follow-up, they had a renal ultrasound, which was normal. For our third case, we're going to talk about a younger infant, 11 days old, with an elevated temperature, who was otherwise well appearing. Maternal history was normal, birth history was normal. They were born vaginally, and the mom did not have any history of infections that she knew about. On the laboratory evaluation, the white count was 14,000 with an ANC of 7,000, a negative urine analysis. And because the infant was in the first month of life, most people routinely do a lumbar puncture, and so that was done as part of the initial evaluation. And the child had a mild pleocytosis with 50 cells, 40 red blood cells with a glucose and protein that were normal, and a gram stain that was negative. So in this case, we would be thinking about bacterial infections and starting empiric antibiotics, but also need to pause and think about HSV infection. Should you send a test, and should you start empiric treatment? So HSV frequency depends a little bit on your population, and I would be curious to hear about how frequently you see it in this population here in Saudi. But in the US, it is unusual. Most of the median age for presentation of neonatal HSV is about 14 days. So our infant at 11 days is clearly in the range where we're thinking about that. But it's uncommon. So when we look at all febrile infants, the frequency is only 0.42%. So it's even less than bacterial meningitis. So if we were to treat every febrile infant with empirically with acyclovir for HSV infection, we'd be treating a lot of infants who don't actually have HSV infection. In fact, you'd have to treat 142 infants in the first month of life and 556 infants in the second month of life to identify one patient with the actual infection. So when we look at the current management of HSV infection in US emergency departments, there's a lot of variability. And so this very colorful heat map looks at quartiles of people that, infants that were tested, infants that were empirically treated, and then actually cases. And as you can see, the colors vary. So there's a lot of variability in frequency of testing, empiric treatment, and actual prevalence of disease. And those are not necessarily statistically related. Can we do better? And I'm just going to mention this because I know this is part of Todd's talk coming up. But what factors are associated with HSV infection in the youngest infant? Youngest age, having a seizure, ill appearing, abnormal triage temperature, having a vesicular rash, thrombocytopenia, CSF pleocytosis, and prematurity. Our infant was less than 14 days of age, had an abnormal triage temperature, and had CSF pleocytosis, having 3 factors that are associated with HSV infection in this study. And so I think empiric acyclovir is likely warranted. So this patient was treated empirically with ampicillin and gentamicin for bacterial infections and received acyclovir. They were admitted. Their quick HSV test was negative, allowing the acyclovir to be stopped, and the blood and CSF, as well as urine cultures, remained negative as well.
5 minutes.
Perfect. So our last case is a more recent case and perhaps something that you've seen in your own emergency department practice. So we have a 7-week-old with a fever of 38.5. The parents come in and they know they have COVID infection. The infant looks healthy. I think you've seen that baby before. We all have. And so the laboratory studies are reassuring. Urine analysis is negative. The procalcitonin is low, below our cut point. And this infant's test, if you can get it rapidly, is positive. Although we would have presumed it was positive based on the exposure history and the parents' testing. So what should we do? Should we do a lumbar puncture? Should we keep the child? This is a challenge because we were forced to make these decisions real time and quickly, but we don't have all the available evidence. And so we had to, do the old risk stratification strategies. Are they appropriate in this clinical setting? So I'm going to highlight one really nice study. The author of the study is our presenter here today, Manoj's wife, who's a general pediatrician at Children's Hospital of Philadelphia. And she did a really nice study to inform this decision-making that I'm going to highlight here. So what they were looking at is at 6 community hospitals associated with the Children's Hospital. They looked at infants presenting with fever. And they had a pre-pandemic period, which was the year before the pandemic, the first year of the pandemic, and then the second year after the pandemic. And so in the first year, there were 231 infants that presented with a fever. In the second year, there were 217. And then in the third year, there were 95. Within those groups, we had a dramatic decline in the number of patients that were, so I'm so sorry. So the 2 higher numbers were the 2 pre-pandemic years, and then the 95 were the post-pandemic year. So we had a dramatic decrease in the total number of infants presenting. But what we see here is the rate of bacterial infections in the post-pandemic years compared to the pre-pandemic years actually went up. So although we had fewer cases presenting, they were more likely to have a bacterial infection. That's likely multifactorial, partly because the sicker kids were coming, the healthier kids were staying at home, and we all were practicing good masking, and so there was a lot less other viral illnesses, even for the youngest infants. So a nice study that informs our decision making that the prevalence of infection of the infants that actually show up appeared to be higher, but the number of infants we were seeing was dramatically declining. So what should we do? There's a little uncertainty, but I think the clinical prediction rules that we derive from looking at other viral infections likely apply. So avoiding a lumbar puncture is probably safe. If the child has any respiratory symptoms in the setting of COVID infection, it's a good idea to get a chest radiograph. But in this case, the child was not treated with antibiotics and they were sent home with close follow-up and fortunately did very well. Okay, in summary, how you manage fever does vary by age. In this small, limited age range, we think about infants in the first month of life differently than in the second month of life. And we have good available prediction rules that help us risk stratify and identify low-risk infants who can safely avoid lumbar puncture, can be treated at home, potentially without parenteral antibiotics. The PCARB febrile infant is a very good rule, which has now been derived and validated. The impact of COVID-19, which hopefully we won't have to be thinking about so much going forward as we have in the past, is a little unclear, but we have some good data that's helping us to inform the decision. If you're thinking about the youngest infants, you have to think about HSV infection, and we have some good risk factors, although it's a very unusual infection. So thank you very much. We'll stay on schedule.